Hi, Professor Lockett. This is Tasha Unrein-Gores for Week 5 assessment. This is my video assessment for eyes. In a clinical setting, if we were going to test visual acuity, we could use the Snellen chart, which would be put on a wall at eye level, have the patient stand 20 feet away, and read down to the smallest letters that they could decipher. A normal vision would be 20/20. Better than average vision would be 20/10, and a tougher vision, which would probably be like mine, would be more like 20/30 or 20/40. Another acuity test that you can do is the near, with the Snellen chart as well, you can do each eye separately to test the acuity individually. But with the reading nearsighted, you'd have printed out where a patient would hold it 14 inches, away from the face. You could move it in and out to see if they can adjust that reading. A normal reading would be 14/14. So the confrontation test is what we use to test peripheral vision for the patient. So I'm going to give the patient a piece of opaque paper to hold over his eye, whichever eye you want, sir. And I'm going to hold my piece of paper, opaque piece of paper, over the same eye. We're going to be testing the peripheral acuity from the other eye. So when you see my finger or the target of the pen, sir, please say now.
No.
Perfect, which is when I see it as well. I'm going to come from underneath.
No.
Perfect. And then from up above.
No.
Perfect, which matches my acuity. If a patient could not see it coming in when you see it, pending that your peripheral acuity is correct, then they would have documented decreased peripheral acuity. And you'll do that to both sides. So again, covering that, and you tell me, sir, when you see the...
No.
Perfect.
No.
And one more.
No.
Perfect. All right. So then we have a couple other tests that we can do that test for the ocular muscle function. The corneal light reflex is about a foot away from the patient. You have them just gaze straight ahead, so gaze at my nose, sir. And with the light, I'm just going to shine up into the... Open up your eyes nice and wide for me. I'm going to shine up, and the light reflex, or that's reflected on the cornea, is symmetric. An asymmetrical reflection of the light would be an abnormal, although babies up to 6 months, that can be considered normal. The cover test is where you'll have the patient stare in the distance across the room, sir. Even though something may come in to block your vision, I want you to keep your eyes focused. So you would cover one of the eyes. The eye that's covered is the one you're testing. His eye remains focused in the distance, no relaxing or drooping of the gaze. And you do that to both eyes, and you would want both eyes to, again, remain focused ahead and not relax. A relaxing of the gaze, again, would be a weak extraocular muscle. And then the diagnostic positioning gaze is where they're using your eyes. So you're going to follow my rays. We're going to go from inside to out and back in, and move just your eyes for me, sir. So you go up, you do 6 different rays, in and out, progressing clockwise. And you're looking for parallel movement throughout all of those gazes. I did a little extra one there. He has parallel movement, symmetrical. If you had one eye that wasn't moving, again, that would be testing for interocular weakness in the muscles. And so then just a general inspection of the patient's eye structure. When they're coming in, you're going to be able to see how your patient walks in. Are they able to tell where the chair's at, or do they have to kind of feel around, or are they squinting? And that would obviously be, he came in with a stable gait. He knew where things were. He was able to walk around our mess of an apartment, so his visual acuity in our moving space is actually very good today. Again, abnormal would be the groping around the environment with the hands. Eyebrows are present and bilateral and symmetrical. They move with his expression. They are both present. Them being absent or unilateral or not equal movements bilaterally would be the abnormal. Eyelids, it's natural for the upper eyelid to naturally come across the superior aspect of the iris, which he has. Lower eyelids, it's normal to be how they are. The hair's coming up and away. An abnormal would be a lid lag. And periorbital edema. Eyeball alignments, you want them to be normal and symmetrical. His are normal within his eye sockets. They're not sunken in or protruding, which would be exothalamus or endothalamus. The conjunctiva and sclera, we assess by pulling down on the lower eyelids using the bony ridge right there, not pushing pressure on the eyes. His is clear, transparent. I see blood vessels. The eye is moist and glossy like it should be. Abnormal would be a change in color, it being jaundice, those kind of examples. Looking at the lacrimal apparatus, you'd have the patient look down and you're going to, with your thumbs, pull up on the inside of their eyelids where you can see the conjunctiva and the puncta, which is not reddened or swollen. It's natural pink. No lesions or anything noted on the eyelashes or lids. We're inspecting the anterior eyeball access or structures, so the cornea and lens. I'm going to have you look straight ahead again, sir, and we're going to shine a light from the side of it. Eyes nice and wide open. Sorry, he's been working all day. And you're looking for a smooth cornea, nothing rigid, no cloudiness. The iris is blue, no big macules or anything noted, but that can be expected in people with darker skin color. So the size and shape of the iris and pupil. They are round, regular, equal, reactive to light. And so with the papillary reflex test, again, sir, I'll have you look straight ahead. And you do the light to see if it's reactive, if his pupils are reactive to light, and if the other one, nice and wide, and if the other eye, the pupil has the same constriction when this eye is affected. So his accommodation, he would have norma perla, which is pupils equal, round, reactive to light, and accommodation. So inspection of the optic fundus, which would be with a regular otoscope, although we don't have one, so I would use this. You would have your finger up so you could control to focus, and you bring it close to your eye and be able to be about this far away from the patient coming in and looking at different aspects. And so we're looking at the optical fundus. We expect there to be pairs of arteries and veins that naturally go to each quadrant. They are straighter on the nasal edge. The optic fundus color should be creamy, yellow-orange to pink. The shape is round or oval. Margins should be distinct and sharply demarcated. Nasal edges may be fuzzy. And the cup disc ratio, distinctness varies. When visible, physiological cup, brighter yellow, white width is no more than half of the disc diameter. The retinal vessels, we know, can have some mild twisting. That this can be normal due just congenital. There should not be any indenting or sharp drawers within the vessels. So the general background color should be light red to dark red, depending on skin tone. Integrity is clear, and the lesions should not be obstruct the retinal. There should be no lesions or anything that should obstruct the retinal structures. Abnormalities within those retinal vessels, absence of major vessels, the AV ratio, arteries are too constricted and the veins are too dilated. The caliber, focal constriction, neovascularization, proliferation of new vessels, AV crossings, tortuosity of the vessels, if there's pulsations or absence of those pulsations is actually the abnormality. And any general lesions, hemorrhagic, any changes in visual structures, and the lesions or hemorrhage on the macula is what we're concerned with. And that concludes my eye assessment for this week.